Gostaria de convidar e agradecer a presença do Dr. Masahiko Asami, que veio do Japão e vai nos apresentar um caso clínico extremamente complexo e também as novas tecnologias, e depois, complementando essa linha, nós iremos para o nosso colega da Nova Zelândia. Dr. Masahiko, muito obrigado. Thank you very much for coming, and we are ready for you.
Okay, so good afternoon, everyone. So first of all, I'm sorry I cannot speak Portuguese, so I will talk about my presentation in English today. So anyway, so it's a great honor to present AI, real-time AI technology to support complex procedure today. So this is my disclosure. So I'd like to talk about complex SHD intervention with current technology first. And after that, I will talk future intervention with AI technology. So patient was a 49 years old female who had developed symptomatic severe aortic stenosis due to a failed bioprosthetic valve and thoracoabdominal aortic aneurysm enlarged to 63 millimeter. She had high surgical risk with SDS from 8.9%, and her clinical quality scale was 1, and her lifestyle was active and independent. So she had multiple comorbidities such as steroid-dependent polyarteritis nodosa, myelodysplastic syndromes treated by steroid and immunosuppressant, and transfusion-dependent idiopathic thrombocytopenic purpura. And she also had a complex history of aortic surgery. 20 years ago, she had an acute aortic dissection at the ascending aorta. And she underwent ascending aorta replacement. And 7 years later, her aortic root was enlarged. And then she underwent ventral operation using SEP 25 millimeter for aortic valve replacement, and hemisphere 34 millimeter for aortic root reconstruction, and Gersoft plus 8 millimeter for coronary reconstruction. And then in 2021, she had again distal arch aneurysm, and she underwent distal arch replacement like this right side schema. And here you can see laboratory investigations. She had normal renal and liver function, but NT-proBNP and CLP and D-dimer was quite high, and hemoglobin level and platelet level was low. And EKG shows normal sinus rhythm with no bundle branch block. And transthoracic echo reveals severe aortic stenosis with normal LV and RV function, no pulmonary hypertension, and trivial aortic insufficiency. And she had no significant coronary stenosis. And the multi-site CT revealed enlargement ascending aorta and ST junction. And both right and left coronary height were enough high, and membranous septum was 11.4 millimeter, and no horizontal aorta. The perimeter of the annulus was 73.9 millimeter, and area were 430.8 square millimeter. And both right and left BTCs were enough long to perform valve-involved TAVI. So therefore, we had an app show that we could use several type of THV. So therefore, we had determined to use the Evolute in this time. And you can see tortuous aorta and a huge thoracoabdominal aneurysm. And descending remains at the top of arch, and you can see huge aneurysm, and true lumen is quite small, like this. And the dissection extends to the terminal aorta, but luckily the bilateral femoral artery are intact. And then true lumen is, again, this small side is a true lumen. And then again, I show you complex anatomy of this particular patient. So here is a ventral side and ascending aorta replacement side and distal arch replacement side are blue. And from here to here. Whoa, okay. And then native arch with a dissection. And here you can see detailed analysis of CT scan. And then I'm checking the which is a true lumen. And the true lumen is go up and the right side from my side. And the next slide go up to the true lumen and it's a front side of aorta. And going down to the aortic valve. And then this is also true lumen is front side going up and then here from right side to left side. And then going down. Yeah, I think this is a quite complex anatomy. So in summary, in our local heart team discussion, Saba cannot be performed first because her aneurysm is about to rupture. So our surgeon said if she underwent surgical aortic valve replacement, she need at least 2 months to recover her condition. So, but she cannot wait. So that's why we additional discussion. And surgeon said it's difficult to perform dissection surgery in the lateral position in the presence of severe aortic stenosis. And then it's also difficult to perform simultaneous surgery. So that's why the best option we thought would treat AS first by TAVI, if possible, and then treat the aneurysm as soon as possible. The anatomically valve-in-valve TAVI procedure was accepted, and we had determined to perform valve-in-valve TAVI with evolved Pro-Plus 26 mm. Now, after puncture of right femoral artery, I advance a wire through the true lumen by a TTE guidance, like right side and the upper panels. At the top of the arch, I advance a wire by TEE guidance, like this, and then you can see this is a true lumen. I try to cross the wire and then guided by GR4. And then I try to cross the wire like a left side panel, and then I cross the wire successfully, like this. And then I use a 20 French 65 centimeter long Cs, and it has reached the top of the arch carefully, like this. Carefully advance the Cs. And then actually I thought that Cs would reach the ascending aorta. Unfortunately, it was a few centimeters short of distance. And I had tried to deliver the THB with some resistance, but I could deliver it to the ascending aorta. Just a moment, I try to push the THB with some resistance, and then I advanced it, but like this. And then after that, I try to advance more, but the THB did not cross the aortic valve like this. And then, therefore, I changed the wire to the Landakist, which was the stiffest wire in Japan, and then used the snare technique simultaneously, but it did not work like this. And then the next step was delivered with the support of PTA balloon, and finally we have successfully passed the THB to the failed bioprosthetic valve like this. And then implantation step were normal. I open the bulb slowly and carefully like this and check the position. It was not bad. And open a little bit more slowly. And then we have successfully implanted the THB without any complications like this. And this is a final assessment. Ultrography showed good result. However, in this younger female patient, we should provide intervention with less radiation and less contrast media dose as possible for her future. And after TAVI, she had undergone a graft replacement for thoracoabdominal aneurysm. Then she is currently in good health. So next is the future intervention with AI technology. So today's main topic. So in the medical field, artificial intelligence has been bringing about dramatic innovations. Interventional treatment is expected to become much less invasive in the near future through the use of AI. However, it is only being used for post-processing of obtained images so far. With the advantage of technology, the time has finally come to utilize such technology for treatment in real time. So less radiation dose, less contrast media, more device and better visibility expected to be achieved with this technology. So here is a question for you. One of these images is for cine acquisition, while the other is for fluoroscopy. So which one do you think is a fluoroscopy? Maybe everybody think about the right side panel, but the answer, the answer is a right side panel. Then, as you can see, the noise in this image is well suppressed, and the vessel looks quite sharp, similar to cine acquisition images. So, what happening here? So now Canon can provide us with real-time, not post-processed AI fluoroscopy to deliver unprecedented images. AI is trained during the develop phase with both fluoroscopy and cine acquisition image. A neural network is trained to minimize noise in order to achieve cine-like fluoroscopy. And AI processed fluoro can provide us with two major advantages. First is a high-quality fluoroscopy with ultra-low dose, like left side panel. And the second is a high contrast depiction, like right side panel. So let's take a look of each of them one by one. So the first is a high quality fluoroscopy with ultra low dose. The left side panel is a conventional fluoroscopy image with a low dose setting. Unfortunately, there remains noise in the image. In contrast, the right side panel is identical low dose setting processed by Canon's AI technology. As you can see, even with low dose fluoroscopy, stunning images were obtained. The AI suppressed the noise in real time to the greatest extent possible. The next benefit from AI processing is high contrast depiction. So Canon's next generation image processing will employ not just AI technology, but also multi-frequency processing to optimize noise conditions. The contrast to noise ratio measures how much the key details in an image illuminate in comparison to the unfavorable background noise. And the CNL increased by nearly 2.1 times due to Canon's latest technology. So here you can see this is a comparison between conventional fluoroscopy and an AI processed image. With this technology, you can obtain deeper perception of vessel anatomy and gain better comprehension in challenging situations like steep angulation or obese patient. Also, the basic image quality will be drastically improved. You can minimize the use of contrast media and X-ray dose for your patients with this technology. So, according to the pilot site in Japan, they succeeded in reducing X-ray dose by up to 30% compared to the normal system setting. This is their pilot experience, but I believe the day will come soon when we can achieve further contrast and X-ray dose reduction utilizing this kind of real-time AI technology. So, currently our hospital has 2 cath labs equipped with Canon angio system to handle various interventional cardiac operations. So, lab 1 is equipped with an 8-inch flat panel detector dedicated to PCI and EP procedures. I explained my lab 1, and then lab 2 is equipped with a 12-inch flat panel detector, Canon exclusive detector size suitable for PCI and SHD procedures without compromising steep angulation due to the compact detector design. So our cath lab is busy all day, and the latest technology is always beneficial in improving our productivity and the throughput of our daily clinical practice. So, ladies and gentlemen, here you can see the take-home message of my presentation. So, based on the advancement in catheter technology, catheter interventions have been spreading to patients in need of more minimally invasive therapies. Therefore, medical imaging is evolving in accordance with device treatment advancement, and AI technology has started to be utilized for real-time imaging for less invasive therapies. So, cardiologists should monitor this advancement for pursuing continuous improvement in daily clinical practice. Well, thank you for kind attendance.
Thank you very much, Dr. Asami. I have 2 quick questions before we move to New Zealand.
Sure.
First, regarding to the extremely complex case that you showed, I have the curiosity, what size of the balloon that you use, like a body balloon, to go inside to the valve, to cross the valve?
Sorry, I totally forgot. I written the size in my slide.
But it's about 2018.
No,
it's a big one or no?
Not so big. Maybe 12 or 14. 14.
14. Okay.
Yes.
Okay. The second question about the technology, the AI technology. How often do you still use cine in your practice? You go only with fluoro, or you still use cine?
Yeah, actually, I mainly use fluoro, so not angio, but I can see the clearly image to perform any procedures like PCI, CT operation, and SAG for TAVI and mitral clip and appendage closure, but easy to perform.